We also have Daivd Faleck here from our gastrointestinal service, who will also be sharing some information about other problematic toxicities, and namely colitis. And Daivd has a unique background with IBD and trying to understand this from a GI perspective, and we'll look forward to hearing what he has to say about this.
Thanks, Mike, and thanks for inviting me today. So we'll go to the other end of the spectrum in terms of frequency. So we just heard about very rare toxicities that I don't know how many people encounter on a routine basis. Clearly, colitis is something that everyone using the immune checkpoint inhibitors is well familiar with. I'll try to give you the perspective of a gastroenterologist as we try to learn more about this disease. So just as a brief overview of immune-related adverse events in general, we know these are incredibly common. Up to 90% of patients on anti-CTLA-4 and 70% on anti-PD-1 develop some form of toxicity. And then when you look at across organ systems, we see that GI toxicities are incredibly common, especially amongst all the toxicities. However, when you focus on the most severe toxicities, the grade 3 to 5, this is where the GI really comes to the forefront and is really quite debilitating for our patients and really challenges us to develop better ways to manage these patients and think about management strategies across a large number of patients. So I'll go through a little bit about some of my thoughts on how I manage this in terms of an algorithm, and then take you through some of the latest data in the field. So when a patient comes across my practice with diarrhea or colitis developing an immune checkpoint inhibitor, we start with a pretty sort of basic workup that we would do for any patient with new onset diarrhea. So we're thinking about some basic blood tests, inflammatory markers we use a lot in the GI world in inflammatory bowel disease, and of course stool studies to rule out infectious pathogens. I'll mention the fecal calprotectin. This is a sort of a unique GI marker that we use a lot in inflammatory bowel disease that was making some sort of headway in the immune checkpoint world. This is a marker of neutrophilic activity in the GI tract, so it's sort of the CRP of the GI tract, so maybe a little bit more sensitive and specific to GI toxicities, and so we're trying to understand how to best use this in the field. And when I think about sort of some pearls on the blood tests here, things that to me are red flags are any kind of metabolic derangements that would suggest really large volume or significant diarrhea, kidney injury, hypokalemia, and then whether there's an inflammatory process going on. And these are the patients that we're most concerned about. Is there really colitis that is affecting the patient? And extrapolating from our experience with ulcerative colitis and Crohn's, the markers for us of severe disease are really hypoalbuminemia as a negative inflammatory marker, and then a high C-reactive protein or high fecal calprotectin are particularly concerning and raise our flags that there's a more significant disease burden going on. And in that vein, those are the patients that you're really thinking about an early kind of objective evaluation with either endoscopic, that we'll talk about more in a moment, or maybe some kind of scan. So some pearls just thinking about those objective markers of assessment. So is CT good enough to look for colitis? So there was one study that compared the diagnostic value of CAT scan versus endoscopic evaluation. CT has a very good positive predictive value, so if you see inflammatory changes on a CT, this is highly concerning for biopsy-proven colitis. However, it has quite a poor negative predictive value. So I see often in practice patients are referred who had their sort of recent staging imaging for their cancer, and there was no mention of colitis, and that is often a false reassurance to the referring physician, because it really does not have a great negative predictive value. So a lot of our colitis is mucosally based, and you may not pick it up on a CT. Another question that we often get is how much of an evaluation is needed? Do we need to do a full colonoscopy? Is a flexible sigmoidoscopy enough? I think we are still learning more, but there was a recent meta-analysis that looked at most of the published experience with this and found that 98+% of colitis involves the left colon, which would be reachable on just a basic flex sig. This is something we've, in my practice, we've actually piloted in the office. So this can be done basically in about 5 minutes for a patient. As part of their office visit, we can take a quick look, just a minimal prep, no fasting, no anesthesia, and we can get an answer almost 100% of the time in a very rapid fashion. So this is, I think, is an important tool to keep in mind, especially if there's any diagnostic uncertainty. but also in thinking about prognostication. So what is the role of endoscopic evaluation? I think I debate this with our oncologists here a lot. Should we go straight to treatment? Should we have these patients all evaluated? And talking with colleagues who do what I do across other centers, there's a huge variety and variation in practice, where in some centers, every patient will go across the GI before they're started on treatment for colitis, and some, we're sort of consulted only in the most difficult and refractory cases. So this was just sort of as an illustrative point. This is a clinic in France where they specialize in the management of immune-related adverse events. 44 patients were referred for suspected GI toxicity, and remarkably, only half of those actually truly had colitis. So, this may be a little bit of an underestimate in terms of what we see, but I would say probably about 80% of patients maybe truly have colitis, but that means that there may be 20% that were wrongly diagnosing. And so there are patients that were probably undertreating and others that were overtreating with immune suppression who may not need it if we're not confirming the presence of colitis with any kind of objective markers. And then the second place where endoscopy really has probably value, and I put great stock in this as a gastroenterologist, is what does the colon look like, and what can we learn prognostically from this? So there are a couple of studies now that have found that endoscopic severity is probably the best correlate for how these patients are going to do and what they're going to need in terms of treatment. And so this is probably a much better predictor than what the CT-CAE diarrhea grading, which I think we all know has its issues. But when you look at a colon and you see, are there severe ulcerations? Are there deep ulcers? Is there extensive anatomic involvement? These are the cases that get us worried in gastroenterology for risk of perforation and severe colitis. But also it turns out that in studies that have looked at this retrospectively, those patients had a much higher need for biologics, for failing steroids, for example, and requirement for infliximab. So in one study, about 80% of patients needed infliximab if there were ulcers during an endoscopic evaluation, were only 44% if there was no endoscopic ulceration. And similarly, in another study, much higher biologic requirement if there's extensive or sort of severe features at the time of endoscopy. Patients needed more and longer hospitalizations. So we can assess very early on for the presence of these severe features and maybe guide therapy rather than waiting for patients to fail when we know that 80% of them are going to fail steroids alone. If we get that assessment early on. So sort of to take through the management part of our algorithm, then I think this is something that all the oncologists sort of do in their routine office. So this is nothing all that novel. We're starting with the grade 1. Usually you kind of watch these patients for a day or two, see if this is a transient, something they ate last night, or this is something that's going to be a sustained issue. If they're not getting better after a couple days, or they're presenting with grade 2, then we're starting them on some kind of steroid, usually a low to moderate dose steroid off the bat. And if those patients are not getting rapidly better, or if they're presenting with more significant symptoms off the bat, we're starting with moderate to high dose of steroids, or thinking about admitting for IV steroids for the sicker patients. And this is the setting where we're really thinking about the role of biologic, and we'll come back to this because I think that's one of the cruxes that we think about in gastroenterology, is where to position these biologics, how soon to introduce them. We typically, the management algorithms that have been developed are really what I call a step-up approach, where these biologics are used for patients who have failed steroids or maybe who are flaring with taper. The main biologic, as we all know, has been infliximab, although there are some emerging data for vedolizumab, which we'll talk about shortly. So what do we know about infliximab? So we know that there's a long experience in the management of autoimmune diseases. It was approved for Crohn's disease in 1998, and so we have in the IBD world over 20 years of experience with how to manage this drug, how to use it. But what do we know about it in immune-related colitis? So this comes from, of course, our melanoma group here. About 300 patients treated with IPI at a dose of 3 mg per kg. About a third of them developed diarrhea. And these numbers have been replicated across multiple cohorts pretty consistently. And then if you look at the patients who developed diarrhea, so 50 out of 87 ended up requiring immune suppression. And then when you look at the breakdown of what they needed, about half of them, or a little over half, required infliximab plus steroids, whereas a little under half required steroids alone. So clearly, so probably the corticosteroid response rate, at least in the CTLA-4 patients, is probably close to about 50%. So a lot of these patients really are going to need something beyond if you plan to treat them appropriately up front without being on especially very long courses of corticosteroids. So we need to get comfortable with the biologics and probably be thinking about using them earlier. But then it sort of begs the question, how well do they work? And so if you look at the early experience here of the 29 patients that were treated with infliximab, 21 or about 70% did well with infliximab, often with one dose, some requiring a second. But a substantial 30% minority still didn't really respond all that well. And sort of in the early days before we had a lot of other options, were often just managed with long courses of steroids, but at great cost to the patients in terms of morbidity, side effects, and impaired quality of life. So as a gastroenterologist, what are we thinking about when infliximab is not working? Because this really still is considered the mainstay of corticosteroid refractory treatment. So clearly, if we haven't yet confirmed the diagnosis, I would strongly urge that this be the point where we see the patient and make sure that we're treating what we think we're treating, rule out alternative diagnoses. We know, especially once the patient's been immunosuppressed, the risk for opportunistic infections, and especially CMV colitis, which doesn't really show up well on any non-invasive testing. So we need to do a biopsy to look for that. But assuming we are treating the right thing, so what are some other approaches that we can take? So one is this idea of accelerated or escalated dose of infliximab. So borrowing from our experience with acute ulcerative colitis, we've come to understand that when patients have a large inflammatory burden, and the patients with acute colitis have a tremendous amount of circulating TNF and inflammatory cytokines. Their C-reactive protein is usually through the roof. Their albumin is low. They develop what's referred to as a TNF sink, where you give them a dose of infliximab and it is very rapidly used up. Basically, by circulating TNF, there are fecal losses, so you can actually measure infliximab levels in the stool, and you'll see that patients with acute colitis are actually losing large amounts of it in their stool. And it's a protein-bound antibody, so the patients with low albumin just don't have as much circulating infliximab. So if you measure their infliximab level after a couple days after administration in the sickest patients, it will basically be undetectable within days, even though the half-life should be a couple weeks. And so we've learned in the IBD world that we can give, and we often need to give more and higher doses in the sickest of patients. So sometimes we're starting them off at 10 milligrams per kilogram if they have some of these bad prognostic markers, high C-reactive proteins, low albumins, severe ulcerations at endoscopy, or repeating dosing in a shorter fashion than the typical 2 or 4 week intervals that we would see under standard dosing. So that's an approach that we've taken in immune-related colitis as well, with some success. And then we'll talk a little bit about some salvage therapies that we think about as possible next line in treatment. And the two that we'll talk about today are vedolizumab, and we'll mention fecal microbiota transplant, although other things have been tried in limited fashion, so not much data in terms of other monoclonal antibodies, such as ustekinumab, which is an IL-12/23, JAK inhibitors, mycophenolate, or a drug like abatacept. So the main drug that's sort of come into the equation as maybe a second line or potentially even a first line biologic is vedolizumab. It was interesting that Bianca mentioned natalizumab, which is used in MS. That was sort of the progenitor of this vedolizumab drug. They both are anti-integrins, but the alpha-4 beta-7 is a gut-selective integrin. And so this drug was basically designed to target only GI mucosal-based inflammation, and it inhibits leukocyte trafficking to the gut. It was approved about 5 years ago for Crohn's and ulcerative colitis as a standard fixed dosing that you see here. And then really the main advantage of this drug is that being gut selective, it has a much superior safety profile to our more broadly suppressing agents ranging from steroids to anti-TNF agents, both in terms of infectious risks and long-term, which obviously is probably not the concern here, in terms of malignancy risks. The cons that I think have limited its uptake, other than lack of familiarity, is the perception of slower onset, which we see in inflammatory bowel disease to an extent, as well as the fact that it seems not to work as well once the patient has already failed an anti-TNF. And whether that's mechanistic, biologic, it's not completely well understood, but that's a phenomenon we see in IBD as well. So what's been the experience? So this was the largest cohorts reported to date last year of using vedolizumab in this patient population. They treated 28 patients across 2 centers with vedolizumab for steroid refractory disease, 9 of whom had already failed infliximab, but then, as you can see, a lot of them were moving this to first-line biologic, and so 19 of these patients had not yet failed infliximab. And the response was actually fairly earlier than I think some of us had anticipated. So in a median duration to initial improvement of 5 days, which is fairly robust. And I think we've seen that across even infliximab, that the response rates seem to be more rapid than we see in our chronic inflammatory patients. And there's probably just some difference in their biology that is driving this that we don't quite understand. And overall, after a median of 3 doses of the vedolizumab, 86% of the patients achieved a sustained clinical remission. The patients who had never seen infliximab before doing much better overall than the infliximab failures. But concerningly still, a very large total steroid duration of almost 100 days across that patient population, meaning we need to be optimizing and thinking about treatment strategies early if we're going to spare these patients the long-term steroid use. So thinking about how to use biologics in that vein, so 2 thoughts that I'll sort of pose to the group is, so should we be using biologics earlier on in the treatment algorithm? So some data emerging for this approach. So early biologic, defined in this study as initiation within 10 days of symptoms, was found retrospectively, of course, to cut symptom duration in half from 25 days to 50 days. Steroid duration was non-significantly, but numerically lower, and the patients had a lower rate of hospitalization. So we may be able to do better if we think about it and sort of pull the trigger on these steroid-sparing but potentially more effective therapies earlier on. And then a second point is there a role for multiple or what are called scheduled dosing, something that we do, of course, in chronic diseases, but not so much in, I think, the traditional oncologic approach here, where these are basically used as ad hoc dosing. So a dose of infliximab here, see how they do, bring them back, in a month or 2 for another dose if they need it, if they're failing their steroid wean. But maybe we need to be more proactive about this and facilitate the weaning of steroids and decreasing the rate of complications by giving them a couple doses in a more proactive fashion. Again, very limited data for this approach, but in one study, if you compared patients across who got 1 or 2 doses of a biologic, this was a combination of infliximab and vedolizumab, to those who got 3 or more, there were no differences in infectious adverse events, importantly, which I think would be a concern of many physicians. But the rates of recurrent colitis were dramatically lower in patients who had completed at least 3 doses of a biologic. So 3% in those patients versus almost a third, or 28% in patients who only had 1 to 2 doses, suggesting that the inflammatory process here is really going on for probably 1 to 2 months, not just a couple weeks when the infliximab is already out of your system. And maybe if we sort of treat them through that whole period, we can decrease the relapse rate. So coming back to our algorithm, after we've added a biologic, we're thinking about whether we need to optimize that biologic. So we're considering adding this early if they predict it to have a severe course, for example, with colonic ulcerations, and then thinking about optimizing the medication that we've chosen, either with higher doses, additional dosing, or maybe prolonged dosing intervals to try and reduce the risk of relapsing colitis and long steroid dependency. The thing I'll mention very briefly, but not get into today because of time, is we've seen all kinds of atypical GI presentations, so not all diarrhea is colitis, and there's a broad differential for diarrhea across these patients. We've seen upper GI disease, so small bowel disease that looks like celiac and rarely can actually respond to a gluten-free diet, and they can actually make anti-celiac antibodies. So something to think about in sort of an atypical presentation. Pancreatic insufficiency has been reported. Asking about steatorrhea and fat malabsorption, thyroid disease, et cetera. So it's important to keep the differential broad in terms of diarrhea. A question that I heard come up in the last discussion that I'll mention briefly, which has fairly limited data, but in GI, because of how much toxicity we see, we're starting to see some answers to these questions, so can we resume immune checkpoint inhibitors after a patient develops colitis, which is a question that I'm asked all the time. And so there are a couple cohorts that, depending on how you configure what you were treated on when you develop toxicity and what you end up with, the rate of recurrent colitis is somewhere probably between 5 and 30%. So it's a large range, and I think we probably need more studies. But is there anything we can do to mitigate that risk or prophylax these patients? And we know that budesonide up front was found not to help reduce the risk of colitis, but anecdotally, we're starting to treat some of these patients with concurrent biologic therapy, which is often well tolerated, while we re-challenge them. And there were 2 recent sort of case series that looked at this, one with infliximab, where 4 patients were treated with re-challenge and all did well in terms of good outcomes out to about a year. And then Vedolizumab as well. So in a study of 14 patients who resumed on an anti-PD-1 after their colitis got better, and the patients who were maintained on Vedolizumab during re-challenge only had a 13% rate of developing colitis, as opposed to 50% in those who were re-challenged off of any biologic. Again, very small numbers. We don't know the effect, the long-term effects or the effects on the tumor, but it's something that we're encountering in practice, and I think we need more prospective data for. We're not going to have, we heard a little bit about the microbiome this morning, but we can't get through a GI talk without mentioning it briefly. So we know that there are good data for the role of the microbiome in anti-CTLA-4 and anti-PD-1, both for tumor response and for development of colitis, which often seem to go hand in hand. But how are we using this or thinking about this therapeutically? So we heard about some of the experimental mice models of fecal microbiota transplant. And then I think many of us are familiar with a case report that came out at the end of last year from MD Anderson, where they used FMT in 2 patients that had very refractory colitis with very good response. So that we were sort of interested in this before that, but that certainly piqued the interest of this on a larger scale. So we've done this twice here. I'll tell you only about the case that went well. The other one ended up with surgery. But I'll tell you about a patient of ours that we started seeing earlier this year. This was a 6-year-old lady with lung cancer who had neoadjuvant 2 doses of an anti-PD-L1, then went to surgery, and then about 2 months later had onset of severe colitis. You see her sigmoidoscopy here on the top right. She had an inflamed erythematous colon, sort of very superficial erosions, no frank ulcers at that time, but was just incredibly refractory. It's a moderate to high dose steroids, 3 doses of infliximab, including a higher dose, and then 2 doses of vedolizumab, and we were sort of throwing up our hands, trying to figure out what to do next with this lady. Incredibly debilitated, so we decided to apply to try to do a compassionate use fecal transplant. We admitted her in March, put her back on IV steroids because she was so debilitated. If you see her colon here in March, does this pointer here work? These are all ulcerations, so despite all these treatments, her disease progressed endoscopically. We biopsied, it was negative for CMV, other infectious etiologies. But you see here we're doing a fecal microbiota transplant, basically squirting somebody else's poop into her colon. And at this point, she actually had a rapid symptomatic improvement. We were able to taper her off of steroids. Unfortunately, the next month she developed a pneumonia, probably related to all the drugs that we slammed her with to suppress her immune system, was treated with antibiotics, but did better, and her colitis relapsed. Again, telling us something is going on with her microbiome that is of great importance, but this was a little disheartening. But at this point, decided I didn't want to immunosuppress her any further, but let's try another fecal transplant by itself to see if this has any sort of sole validity without other drugs on board. So we did a second FMT. Within a week or 2, she went into a complete clinical remission. A follow-up sigmoidoscopy a couple months later showed complete healing of her colon. So again, it's sort of a proof of principle. We need more data for this, but an intriguing approach that I think we're going to hopefully learn more about in the near future. We're launching, hopefully in the next couple of months, a pilot study. So if you have any patients who you want to refer, you can let me know. We hope to be live with the study in a couple months of doing this for patients who have severe colitis, refractory at least to steroids and or a biologic. And we'll look at some scientific and clinical endpoints here. The last thing I'll leave you with is sort of looking forward to the future is can we be more sophisticated and targeted in the drugs and approaches that we're using? So this was a piece, sort of an opinion piece that was published in Lancet Oncology earlier this year. But with GI especially, we have such easy access to the target lesions. Can we learn anything about the immunology of the lesion and use that to dictate what therapy we're using? We're a little bit of ways from doing this. Even in inflammatory bowel disease, we don't really have any great prognostic markers about who's going to respond to which therapy. But thinking about it, maybe there is a difference between a lymphocytic infiltrate and a monocytic infiltrate, and maybe this should dictate what drugs we choose and how we order them, and maybe bypass some of the non-specific drugs that we're giving with potentially off-target effects. So just to summarize, we know that GI toxicity of checkpoint inhibitors are incredibly common and severe, occur up to about a third of our patients. They are, we didn't talk about too much about it, but they probably have some anti-tumor response in the patients who develop GI toxicity. We know that multidisciplinary management of the toxicities is important, and especially early recognition and early treatment, potentially with steroid-sparing therapies, may be helpful in decreasing the morbidity for our patients. And the more we understand about these diseases and the immunology, I think we can really make inroads into treatment. So thank you.
Thank you, David. That was wonderful.